I'm Terri Edmiston, and I'm presenting on advocating as a leader. The objectives of this, at the end of this presentation, you're going to be able to discuss leadership principles from the bedside to the boardroom, not the first time you've heard that today, promote enhanced leadership skills in current practice, and analyze the existing strategies to advance leadership across the care continuum. I want to get a little bit of a read on the room. How many nurses? Okay, any social workers? Chaplains? Okay. Any, no CNAs or anything like that. Okay, and actually what I'm going to share with you today is not anything really new. We've heard it throughout the weekend. So this is just kind of wrapping it up into my experience and my practice. Okay. All right, definition of leadership. It's a position as the leader of a group or an organization. It's the power or ability to lead other people, and it's the time when a person holds the position of a leader, and those are from the Merriam-Webster online dictionary. And then the definition of advocacy is the process or act of supporting a cause or proposal, and the act or process of advocating for something. So this is kind of, as you put that together, advocating as a leader is an individual in leadership supporting, mentoring, and advocating on many levels for the greater good. And as I read our HPNA position statement today, and looking at the examples of palliative nursing leadership, I think the advocating that we do goes across all those spectrums: the clinical, the quality, the research. Not my thing. Glad there are people who like to do that. But and then also as well as the advocacy. And you advocate on a lot of different levels, but it all starts with the patient at the core. Everything that we do in healthcare is related to the patient. One of my, as I researched for this presentation, one of my heroes is Florence Nightingale, and I got a great appreciation for the leadership focus that she had, which was centered on improving health and welfare of people throughout the world. So again, whatever we do is patient-centered, and then, you know, as a manager, my position, my other life, is I am a hospice clinical manager for an 8-hospital health organization in Northeast Indiana. So it's my job to, number one, start with the patient, and then advocate for the staff for many reasons that we'll share. Also, it's my job to advocate for my employer. I have a responsibility to them to be mindful of their resources and getting the best, a result for their interests. And then as a nurse, advocating on a professional level. And so those are some of the things that we will talk about today. Okay, as I said, advocating in leadership starts with the patient at the center. I advocate for their staff to provide a work-life balance, which is, we'll talk about that a little bit more as we go on, but that's been a huge focus in my agency for this year. A leader advocates for the employer, making sure to protect their assets to the best of their ability. And then as a professional, we advocate for the profession to assist with the development and betterment of the profession. And, with the patient as at the center, all those principles that we talked about can all go back and forth. You're going to, as you're advocating, you're going to although you start with the patient at the center, you'll realize that they flow back and forth with each thing that you're doing. Okay, a leader is knowledgeable and current in their evidence-based practice. You have to do that. You have a responsibility to help your staff to be able to provide the best care that they can to the patient. So in order to do that, you have to remain knowledgeable in what's best practice and at the time, and you have to use your resources to advocate for patients in teaching them self-care. That's, you know, one of the most important things that we do, because we're not always there, at least in the hospice world. That's my world. We're not always there, and there are so many things that we have to teach them in order to be able to, the family, the caregiver, the patient, to be able to provide the care that they need, because we aren't there, and to, you know, kind of be able to do something until we can get there and help them. Okay, and then we also advocate for the patient to promote self-determination, resolve conflicts, and ensure ethically appropriate care. The session that we had right after lunch this one will not be as heavy as that, but those are some of the discussions that we have to get into and that we have to think about. And number one, that you have to know where you are on the spectrum to be able to help your staff provide that care. And I find for myself, it comes in, I get called into question a lot when my beliefs differ from what I'm being told or what the regulation says that I should do. I personally think that's a slippery slope that, you know, kind of as that conversation went, can really cause some problems, and I'm not sure that it's always for the best of the patient, but it is something that we have to do to work with them to decide what it is that they want, because in the end, it's always about them. It's their show. They do, you know, we are there to help them through it, but it's always about them within legal ramifications. Okay, and also a leader advocates to provide work-life balance with adequate staffing, and I think that's probably a big issue for all of us. The health system that I work for does an employee engagement survey every year, okay? So last year, the results came back, and even though we knew it, the big dissatisfier was call and overtime, and, you know, kind of we're working them to death. And so we really put a big focus on work-life balance this year. Looked at, and actually it was kind of nice, because with this employee engagement survey and the results, I got the ear that I'd been trying to get for years, and it finally, you know, came out. This is what we have to do. Finance guy. If there are any finance people in the room, I'm sorry, but I am a nurse. And so, but finally got that ear. So I ended up adding like 2 new positions, and then I added 2 on-call positions. So I have 2 on-call nurses that all they do is on-call. They're on 7 days, off 7 days. And then also in the process of hiring 2 LPNs, we're divided into Northeast Indiana is kind of a big area. It's an 11-county area that we service, and if anyone's familiar with Indiana, it would probably be, you know, from the Ohio border to kind of the middle of the state, and then south into just about 50, 60 miles north of Indianapolis. So we cover a big area. And so what I'm doing, the way our setup is, because I'm hiring 2 LPNs to also help with that on-call position. In Indiana, LPNs can attend deaths. They can, we can't pronounce, like, you know, I think a lot of people, but we can affirm the absence of heart rate respiration, and LPNs can do that in Indiana. So we'll add that, and so that makes our staff nurses, they are third up on call. So they do have to work the weekends. They're on call from 8 to 5 on Saturday and Sunday, then the on-call person takes over. So before it was, they were on, sometimes depending on how the rotation fell, they could be on call from Friday night to Monday morning, and nobody was happy with that. So that's one of the things that we've done to advocate for the work-life balance for our staffing. And so our results are supposed to be out this week for the current employee engagement survey. So I'm kind of anxious to see what will happen. I've heard a lot and everybody seems much happier, but we'll see. You also have to advocate for the supply, the needed resources to enable the staff to do their jobs. Sometimes it's hard to get the equipment that they need, but so that's part of my job, is to kind of explain again to the finance guy why we need this equipment. And I heard a great idea today. I had thought about it before, but I think I'm going to be a little bit more forceful about it in making him go out and spend a day with a hospice nurse. Because for many reasons, supplies, productivity, that dreaded word, we have, hospice visits last longer sometimes than like a regular home care visit. So those 3-hour visits where the patient's dying and you're there helping the family and kind of doing the pain management, doing all that to get them through it, I cannot get through his head that, that's 3 hours of their time, and I am not going to expect them to go out and do. Until very recently, our productivity for the day was 5 visits. So we've been a little bit above the national average. And so, you can't expect them to do that and then go out and do 4 more visits and get their day done by 5 o'clock and have all their documentation done. So that's kind of, yes.
Just that top one, when it says work-life balance with adequate staffing, I think, and I'm sure I saw this today,
yeah,
we can't determine what adequate staffing is.
Right.
I mean, that is the problem. There's not any evidence-based research to say.
Right.
So when you say 5 visits a day, I used to do 4 to 5 in home care. The agency I'm working for now, the weekend staff have done up to 8 to 10 visits.
Yes.
And a start of care or 2.
Yeah. Yeah.
In one
day. In one day.
That's
yeah.
a 12-hour
It is crazy.
Or a 12-hour day?
No,
No.
they work from Saturday 8 a.m. until Monday morning 8 a.m.
Oh.
But I will be honest with you, we have an inpatient program. Our inpatients are housed in the hospital when there's a bed available, and I will be honest with you, I have a dedicated nurse, and she's just at the hospital every day. She has done 8 visits and 3 admits in a day. And so when, the pressure's coming down to yeah, she's in the same building, so that's kind of like seeing 8 or 9 patients in an ECF. You're not driving. However, you still have the responsibility of all the documentation and everything that goes with that, so that when I get pressure about your nurses are not getting their documentation done timely, it's like, I'm sorry. I am not going to ask that nurse to then go home and do all that documentation and have it done in 24 hours. So that's, that's part of the balance that as a manager you are trying to advocate for them as part of that work-life balance. And I agree, there's no benchmark out there for staffing.
There's NHPCO has a staffing for home care.
Yes.
But there's not one for the inpatient.
No.
That's what I work now with inpatient. Yeah. My goal is a 4-to-1 ratio for an inpatient. Yeah. But we have up to 6-to-1. But you can have, we've had up to 4 deaths and 3 admissions in a shift. We've had 6 admissions in one shift.
Sure.
One day. So to me, if there's any other SIG groups that can happen, is staffing adequacy. Define what
I would love that, because we, as managers, we are asked, okay, so what's the ratio? But there is none out there. There's no benchmark out there that it's kind of industry standard, as we all know. And then if you're looking at, like we are, we're looking at growth, so when we hire someone, it takes a year. We tell them it will take you a year to be comfortable in this position. We do have the blessing because it was finally realized by folks higher than I that if you don't give them, they have a 12-week orientation, and we don't let them go on their own until about week 9, 10, and it's like do a visit, you know, come back, document. We don't let them go because the staff turnover on the home care side, not the hospice, was so, it was like a revolving door. And so that, you know, $40,000 that it takes to orient a patient. So, you know, kind of advocating for that. The flip side of that was hospice, really, we don't have that turnover, but we were beating our nurses to death. So, so the focus, you know, with this focus, it has helped make them a happier group. I think I saw this hand first.
So with a 12-week orientation, how do you speak to the pressure then of, you know, the other nurses on the team? Are they ready? Can they go out? I have 12 patients. I need help. And how do you protect them and say, well, no, we're going to do this the right way?
Right.
Because I don't have any luck as the education manager with that at all. I have so much pressure to get them out. In fact, my preceptors will call me and say, you got to get her out. She's fine. She's fine.
Yeah.
And then I go through the documentation and it's horrible.
Yeah, yeah. I guess I think it's a blessing that I have the benefit of having a very seasoned team, and they're very patient to a point, you know. So they, a lot of times too, they will come to me and say, hey, I think they can go out, but that's, you know, our discussion is, okay, you guys, do you remember last year when you were working yourselves to death because we didn't have any staff? So now we have this staff, they're in training. Give us a couple more weeks or another month. And so I have been lucky in that they have been patient with that answer. So, but yeah, when you look at the documentation, it's like there's no way they're ready to go out. I think I saw one more hand.
So I have two things. As a staff nurse, do you have any sort of advice as how to address that with your management? This is something that we've been struggling with in our home care program because I've only been there a year and there's several other nurses who have only been there a year, and we cannot maintain that work-life balance when we're seeing that many patients. Not just because of the demands of the documentation and the patient care, but also because, you know, it's an emotional drain. And when you get home and you have a family and you don't have anything to give to your family life is affected. And so we're having a higher turnover rate at this point, and we have lots of senior nurses who are coming to the age of retirement.
Exactly.
And we're going to be losing a great deal of our staff, and they're looking to us to maintain it, but we can't do that, first of all, with having a family. But secondly, something that I think as a culture needs to change for us as nurses is we need to stand up for ourselves, because when they come to me and say, oh, I need you to do your 10th visit for the day, or they call and my patient is in distress or whatever, but I have 8 patients scheduled. We as nurses need to say, that's not safe for me to take another patient at this point because you're not getting good patient care. You know, and they're so big on measuring satisfaction. Well, nobody's going to be satisfied if you keep doing this to your nursing staff. So I think it's a culture that needs to change, and maybe that needs to be part of our education with our new staff, is to stand up for yourself. Because under the, you know, Nurse Practice Act, you're not supposed to take an assignment that you feel is unsafe, that you can't provide care. So if you take that report and you're saying, okay, I'll take this patient, then you're accepting the responsibility for that. But if you say, no, I don't feel like this is a safe assignment, yes, it makes your nurse, your clinical leader, or whoever upset because they don't have staff, but it's also not your responsibility as a staff nurse to take care of staffing issues. And I think if people started to voice that more often, and not in a complaining way, you know, because it's one thing, everybody complains in the background about, oh, I'm overworked, I'm over this, I have too many patients, but when someone comes to you and says, can you take a patient, rarely do people say no. So it comes back to us as nurses being able to say no.
I also kind of equate that with what she said as far as having the support of your upper management, which it took a lot for us to get there, and it took many times where I thought, okay, I have stepped in it now and I have to find a new job. And luckily she, you know, would come around to my way of thinking. But right now too, and this has been, I will admit, this has been a hard adjustment for me because I work in a health system, so we don't say no to our health system patients. However, and it took a long time for hospice and palliative, or home health and hospice and palliative care to come to the forefront in our health system. And right now we've kind of, we're in the spot where, gosh, you know, well, we want to get them off of our statistics, our morbidity statistics, but we don't know what to do with them, so call hospice. So and this again was very hard for me, but it's something that I've learned, is that we don't have to take every patient that comes down the pike. I do answer my phone 24 hours a day and get calls frequently about, you know, should I go? I also have the benefit of having a night person, which has also been really helpful. So we're changing our process just a little bit, but if they, you know, again, we don't have to take every patient that comes down the pike. We have the ability, we have not standing orders, but what are they called now? The name for standing orders is something, yeah, care, yeah. And so we will say, right for comfort measures, we will be there in the morning. A part of that too is just, we have found out that they just don't go. If they're inpatient, it's okay. But if they're, you know, we've had 2 of these in the last 2 weeks. It's 4:30 on Friday afternoon, and they're calling and saying, we have this family who wants to take their loved one home tonight on BiPAP. And it does not go well. Again, and also too, opportunities, this is my soapbox, opportunities for education to all staff, because what happens is any nurse in the hospital gives any information that they want before you ever get a chance to get to them, and they set us up for failure. So by the time we get there and things have not gone well, of course, then they're very angry, they're upset, and so you guys all know the story. So we have kind of, with the blessings of our medical director too, been able to go to, put comfort in, and many of them are actively dying anyway. So if we'll be there in the morning, make them comfortable, and we'll be there in the morning. So you need to have the responsibility to mentor your staff in providing evidence-based practice. And it looks like I didn't finish my statement. I don't know what happened there, but providing them with the current information. One of the things that I have started doing, and again, I think I'm pretty blessed to work where I do. For the last couple of years, we've been able to, NHPCO has the virtual conference. And so we've been able to tap into that, and that way, because I wanted to get, not everybody gets the chance to go to a conference or convention. So we've used that as a way to get them the information that they need, and also feel like they've, gotten some current education. Okay, staff advocacy is the in-servicing. We do a lot of in-servicing. Encouraging continuing education. Our health system has many programs for helping. We're also going for magnet right now, so of course the focus is certification and getting your BSN. So lots of programs around that. So encouraging education, encouraging the certification in the practice specialties. And I went so far this year as to make it a goal for their annual evals that they get certified by next year at the time of eval. So we currently have several people who are studying. We've got 2 that have already obtained it. And so, and it's kind of I'm a little bit of a competitive person by nature. And so, what can it, and I also live in an area where Indiana's a no certificate of need state. So there are 20 to 25 hospice agencies in our area, Northeast Indiana. There are 2 not-for-profits, Parkview, us, and VNS, and so lots of competition out there. So, you know, this is one way, you guys, let's do this, and so take our level up just a little bit more so we can use that, you know, to help with our growth here. And also implementing succession planning to ensure a smooth transition when time for leadership. I am seasoned, so I'm looking at the end of my career more than, you know, to the beginning. And so I had this conversation with my boss and have chosen someone that I am mentoring to kind of take over when I move on. And that's an important, you've got to have that, because if you don't have that smooth transition, then the patients suffer, because nobody really, you know, knows what's going on. Okay, employer advocacy. The leader has to stay knowledgeable and current in evidence-based practice. We have to, you know, we all know healthcare is a constantly changing industry, and so we have to be willing to accept and move on with the changes. We have to be knowledgeable in the regulatory requirements. We have to be a lifelong learner. We have to be ready for growth, and we have to be ready for change. I've heard it a lot this weekend where lots of people are an army of one. You know, but what we do is so important. It's up to us to educate the executive level on, you know, what's right and what needs to happen to do this the correct way. We are in the process of opening an inpatient unit because we are at the mercy right now of we house our patients on the oncology unit, our inpatients, and so we are at the mercy of if there's a bed. And so many patients were dying without hospice because there was no bed. So we're opening a dedicated unit. It's not going to be called a hospice unit just because of all the stuff you have to go through, but it's going to be a supportive care unit with the focus on hospice. And then next spring we're breaking ground for a standalone. But it has been amazing to me, the hospice manager, that many of these meetings I'm not even in on. People are making decisions for us that you know don't know so the push is that we need to be able to help them know what's regulatory and what's not. In having to be ready for change, it's like I feel the we've never done it this way before is one phrase that just makes me crazy every day. And I feel like if you are in fact still saying that, you are already left behind in today's climate, because it is changing so fast that we need to know what's going on and pay attention and get that education and that word out to be appropriate for our patients. A leader is a good steward of the resources of their employer. Probably I'm not the only one in the room who's a nurse and is pulled into the financial piece of it more than she would like to be. But I have learned a great deal about, you know, what we can do to keep the resources, because without the funding, there is no program. So. Okay, a leader will advocate for their employer for the greater good and to provide the best care for the patient. Oh, I'm sorry, you guys, we're running out of time, so I'm going to go through this kind of quickly. This morning I said, we're the profession, and there are people out there that are making judgments for us that don't know our profession. So we need to be out there and helping to make those decisions. We need to educate our legislators. We need to join professional associations like HPNA and be active on both the local, state, and national level, and continue to be a lifelong learner. If you're not a lifelong learner, you cannot keep up with what's going on, and advocate for the best for your for staff, employer, patient. We need to take advantage of educational opportunities. We've heard many of the opportunities that are available. If your organization is a member of NHPCO, lots of educational material there. HPNA has lots of educational material. And there's just a lot of associations out there that have good evidence-based practice to help us bring it back down to what we need to do for our patients. Has anyone in the room had the chance to go to the Nurse in Washington internship? Okay, that is something that is sponsored by HPNA. Sorry, it's after a long afternoon, and if any of you are on floor 12, you will know that there was a lot going on there last night until 2 o'clock in the morning. It was right outside my room, so the girls' football team was celebrating. So they won. Yeah, St. Louis, and so...
No, but I kept waking up all throughout the night. I could not sleep.
Yeah, it was right outside my room, so I'm a little foggy right now. But anyway, the Nurse in Washington internship, HPNA put out a call. I wanted to go, so they sent me to Washington. And it's a 3-day, you arrive on Saturday night. Sunday, you start classes, and you have classes Sunday and Monday. They teach you how to approach your legislators. And they teach you the message and how to do it. And this year the message was about, the biggest message, there were a few, but the biggest message was about how practicing to the level of your education for the advanced practice nurses. It was intriguing, so much so that I would go back next year and pay for it to go. It gives you a really bird's eye view of how things get done in Washington. And it's kind of interesting. I have you see the, I'm sorry, what? Oh, you see the representatives in the morning, and then you meet with your congressmen in the afternoon, your senators in the afternoon, which that was kind of, you walk by, there's Ted Cruz's office, there's John McCain's office, there's, But anyway, I was scheduled, I was the only one from my district, so I was scheduled at the beginning of the appointments they're set up to meet with the health education person in from my district. So a day before I got there, they call and tell me that my appointment has been changed, and I'm meeting with the guy who's in charge of farms and trucking and stuff like that. So, and then they emailed me and said, okay, can you come this much earlier? So kind of takes you out of your mindset, But it did, I got maybe 15 minutes with him, and gave him the ask and all that. He said, okay, I'll take this to the boss and we'll see what he does. That was a win. There were 6 of us there from Indiana, and so 2 of them were from the same district. They went to see a guy, and that legislative assistant said, well, that's going to cost $1 million. Where are we supposed to get that money? And they had taught us to respectfully say, sir, that would be your job, not ours. But so it was to figure that out. But so, that wasn't so much of a win. And we all had varied experiences, but it is, if you ever get the chance to go, it's fascinating. It's just fascinating. And take walking shoes. You walk everywhere. And I tell you, 25-year-olds are running the country. So they're all, young. They're just out of college. They've done the public service type degrees. And yeah, it's fascinating. And they tell you will have hallway meetings. One of ours was a hallway meeting. So, they were running from one place to the other. So you've got them, you take them, and you give your pitch. So if you ever get the chance, I highly recommend going.
What's it called again?
It's called Nurse in Washington Internship, and it's NIWI is what the acronym is, but it is fascinating. So professional advocacy and leadership helps to ensure the evolution of one's cause and the development of the program with the patient at the center of all progress. The couple of quotes that I liked, one from John Quincy Adams: if your actions inspire others to dream more, learn more, do more, and become more, you are a leader. Advocating for what you believe is crucial. If you don't ask for it, people are going to assume you don't need it. So in the profession, we need to ask. And then the last quote is from Florence Nightingale: I think one's feelings waste themselves in words. They ought to all be distilled into actions which bring results. Okay. Any questions?
I have a question, Terri.
your annual engagement survey? Is that something you developed, or is it something?
No, our health system, that's run totally by our HR department, and they hired a company, which I cannot give you the name right now, but no, Pressgani, we use Pressgani for our service excellence, our customer service surveys, but it's not Pressgani, it's a different company. No.
Wait, you're going for Magnet, right?
Yes.
And that's why they do it when you're
Annually.
the applications, so
Yeah.
they can see what they're going to be focusing on. Because we do that with my other health system.
Yeah.
And it's amazing, because I was on work-life committee, and no one cared the fact that like more than 30% of our staff in home health and hospice were looking to change.
Yeah.
And I was like, more than a third of your nurses want to
That's
leave
not
within
good,
a year.
folks.
And they were
Yeah.
like, oh, whatever. Let's
Yeah.
look at lunch breaks. I'm like, no.
Yeah, and that lunch break is going to cost you a whole lot less money than the $40,000 it's going to cost you to orient a new nurse. So, yeah, it's kind of interesting.
I think my angst about all of this is that next year I will be a nurse for 40 years. These are the same issues we had 30 years ago. We haven't had, we're doing nothing about it. We have had, and I told my nurses this, and they made me a supervisor because there wasn't anybody else that wanted to be one, but I'm still a staff nurse. And I said, nobody has asked me the statistic, but 60% of the time my inpatient unit staff does not take lunch. Now, they get paid for it, but in what other world profession is that okay?
Right.
And they do it because they're good nurses, they're good people.
They're dedicated to their patients.
There's a lawsuit on that right now. There's a huge lawsuit.
Well, they get paid though, so we can't sue about that, but it's just.
No, we
it's,
have to clock out. We have to clock out on our inpatient
I just read about it.
because of the lawsuit.
That's not even part of, they're all okay, but a lot of them work casual, so they have their work-life balance because they work casual. But the other thing is, there's not any difference in the pay differential than 1977 when I graduated. It's still 50 cents to $1 an hour, in Pennsylvania anyway. I think California, you get more, but that's my angst. This is why nurses want unions in California, but we don't have time to do anything about it because we're so busy taking care of patients.
Yeah.
So I'm going to retire in 2 years, but I'd like to be a lobbyist.
Yeah.
Because it's just, I'm weary about it. We can still take good care of patients because we're doing hospice nursing. We know how the art of nursing. Our speaker this morning was fabulous. But when I see these new student nurses, or Kate, I've been talking to Kate, is these new nurses got to do, we can't put up with it.
Well, they don't.
That's why I love seeing the younger faces in the room, because you guys are the ones that are going to have to take this over. We have not done a good job of representing ourselves. And so now we just have to get better at it. So we're out of time, and I'm supposed to tell you that if you brought information on your chapters, to please pick up your stuff because they're breaking down the tables. Thank you.
Thank you.
Thanks.